Dear colleagues, with the current situation we're facing globally with the COVID-19 pandemic, we at OncoAlert have taken the decision to bring to the world a little more information and bring us a little closer. We want to share with all of our colleagues the information that we have regarding this virus and our cancer patients. Our Italian colleagues have been sharing with us their experiences through our network, and this is the reason that we have decided to conduct what we like to call the OncoAlert Roundtable Discussions, the Italian COVID-19 experience. Our aim is to deliver to the world key points, oncologically speaking, of how we can save lives and what we should be focusing worldwide as an oncology community. What our delegates would achieve, our Italian colleagues, I would imagine, would like to get their knowledge out there and expertise and give as many examples as possible on how to improve the situation for our patients. Our American colleagues and our Swedish experts will probably have questions regarding what we can do to better serve our patients. Our esteemed guests at this roundtable are Giuseppe Curigliano, medical oncologist and assistant professor at the University of Milan; Daniele Generali, medical oncologist, assistant professor at the University of Este, head of oncology at Cremona; Erika Hamilton, medical oncologist, director of breast and gyne oncology at Sarah Cannon, USA; Lena Sharp, RN PhD, head of regional cancer center in Stockholm and PAC's president; and Axel Grothey, medical oncologist, professor of oncology, co-chair of the NCI GI Cancer Steering Committee. We are your co-hosts. My name is Gilbert Morgan, and with me is Dr. Felipe Ades from Brazil. Dr. Ades will now go through the agenda on how this roundtable discussion will go.
Thank you, Gil. It's a pleasure to be part of the team now, and the agenda will go as following. We start with Dr. Giuseppe Curigliano that will show us a presentation of the Chinese COVID-19 development and cases. And following, we open the first word to Dr. Generali, who will tell us about his experience treating COVID-19 in the region of Cremona in Italy. After, we will open the floor for questions between our speakers here, and also for questions from the audience. So, Gil Morgan, please.
So, thank you. I believe I can start in order to be on time. So I will share my screen and my slides. So it will be a very short presentation just to understand how in China and in Italy we decided to contain COVID-19 in a well-coordinated manner. We are not still contained in Italy, so I will show the data of 6 p.m. that are dramatic also today. You know very well that COVID-19 is a beta coronavirus, and you know the history of the wet market in Wuhan. We have different coronavirus and disease, but it's practically very similar to SARS coronavirus and to MERS coronavirus. But if we compare all the coronavirus in the last 50 years, I invite all the other speakers to mute, because if not, I have a lot of background. We can see that most of the coronavirus gave respiratory symptoms. Since 1966 to 2019, we had several epidemics. This is the only one to be declared a pandemic coronavirus infection. So all the data that we have are real-world data. So we have to be very careful in evaluating this data. I saw on Twitter a lot of comments: we do not explain mortality rate in Italy, why is so high respect to Korea and respect to China. Of course, we are assessing actually only symptomatic patients. So we have another type of assessment of the positive cases. So the definition of positive case can be completely different. We have many patients at home that are not tested for coronavirus test, and we know that they are positive. So that's why maybe we have more high mortality rate, but I believe Daniele will discuss about this. So this is the first paper published on coronavirus. It's a Lancet paper in which they presented epidemiological and clinical data of 99 cases with pneumonia in Wuhan, in China. The average age of the patients was 55.5 years. We know very well that in Italy, the median age is close to 70 years old. The median age of the population in Italy is one of the elderly population in the world after Japan. And 67% of patients in China, exactly like in Italy, were men. 49% had an history of exposure to the human seafood market. 51% patients had chronic disease, exactly like in Italy. 23% were admitted to intensive care unit. In the Italian population is 15% that is admitted to the intensive care unit. 17% developed ARS, so these data are not different from the data of Italy, and 11% worsened in a short period of time, in 3-4 days. So these were the symptoms, like exactly in Italy: 83% of patients with fever, 82% with cough, shortness of breath in 31%, and pains in 11% of the patients. There is also confusion, headache, sore throat, rhinorrhea, chest pain, diarrhea, and nausea and vomiting. Chest X-ray usually do not recognize a pneumonitis unless it's very advanced. So CT scan is the best test in order to recognize pneumonia in 75% of the patients with ground glass opacity, and 1% of patients in the Chinese experience had pneumothorax. So look at the approach in terms of treatment. 76% oxygen therapy with 13% with non-invasive face mask and only 4% with invasive. Consider that in Italy, 50% of the patients, 15%, usually are with invasive supportive oxygen therapy. So they are intubated finally. So it's a completely different pattern of patients. And in the Chinese population, we have 3% of patients with ECMO. 71% require antibiotic therapy, antifungine therapy, and of course, all of them antiviral treatment and glucocorticoids. If we look at data in 1,099 patients with laboratory confirmed COVID-19 infection, the primary composite endpoint was admission to intensive care unit, use of mechanical ventilation, or death. If you look at this data, we know very well that 18 patients have been published with cancer, is a letter to Lancet, and the case fatality rate regarding those endpoints for cancer patients was 80%. So it means that many of the patients with cancer usually are admitted to intensive care unit. Of the 7,736 patients with COVID in the Chinese population, the largest patients admitted had been admitted to the Wuhan Jindan Hospital, and the hospital accounted for 19% of all the hospital in China. This was the situation at the beginning, so there is a red zone, exactly like Regione Lombardia, but that is very, very similar as population at this region to the Wuhan-Hubei region. And the median age of patients in China was 47 years old, with 41.9% in this region that were female. So in the Hubei region, we have a different pattern of epidemiology. And the primary component point occurred in 67 patients, 6.1%, with 5% admitted to ICU and 2.3% underwent invasive mechanical ventilation. And the mortality rate was 1.4%. Of all these patients, among 173 patients with severe disease, the primary composite point occurred in 24% of the patients. And among all patients, the cumulative risk of composite endpoint was 3.7%. And among those with severe disease, the cumulative risk was 20%. So everybody is discussing about case fatality rate in Italy, but we have a 15% case fatality rate that finally is very similar to the population of Hubei. Only 1.9% of the patients had an history of direct contact with wildlife. Among non-residents of Wuhan, 72% had contact with residents. So the spread of epidemics is very similar like in Italy. And the median incubation time was 4 days, from 2 to 7. So the quarantine of 14 days is reasonable, but also in Italy, from development of fever and cough to admission to intensive care unit, really the incubation time is 2 to 7 days. And Daniele can provide us data from the real life. Again, fever and cough were often symptoms before admission to intensive care unit. And on admission, of course, the pattern of CT scan was ground glass opacity. That was the most common radiological finding, with 17% with no severe disease and 2.9% with severe disease. 58% of the patients received intravenous antibiotic therapy and oseltamivir therapy. So the pattern is quite similar to the Italian pattern. And the mechanical ventilation with CPAP was common in 32.4%, glucocorticoid for 18%, and the median duration of hospitalization is 12 days. It is quite similar to Italian patients. So that's why once they discovered that there are a lot of patients admitted to intensive care unit, they decided to define restriction, isolation, and containment with prevention of the epidemic spread. And the decisions in China are very similar to the ones that we decided to do in Italy because we shared the data. So for communities with non-confirmed cases, exactly like in Italy, since the beginning of Sunday, there is community mobilization, health education, management of returning personnel from the epidemic areas, and preparation of supplies. For communities with confirmed cases or outbreaks, we have the same as above, management of close contacts and disinfection. And for communities with spreading of epidemics, we have epidemic lockdown area and limitation of gathering. These were the restrictions for China, but actually also in Italy, for any area, there is a complete lockdown. So we have all the country under lockdown. So in China, they decided to generate designated hospitals, also for mild and moderate cases, converting stadium convention center. And you should know that today in the Milan area, specifically in the Milan city, we are converting the exhibition area for an hospital of 600 beds with 300 beds for intensive care unit and 300 for sub-intensive care units. So we are doing exactly the same measures that have been applied in China. So we revised several times the treatment guidelines and the mobilization and coordination in the national medical resources. And we concentrated the resources in major hospitals, identifying some hub hospital and some from cancer hospital. We have actually in Regione Lombardia 4 cancer hospitals that are hub for all the patients in Regione Lombardia. So the idea was to concentrate patients, experts, resource, and treatment. And this was what in China they obtained in terms of reduction of infected cases. So they have success with social isolation and containment strategies. So this was China at the beginning of the epidemics on February 4, and this is China now in March, at the beginning of March. So they have been really successful in reducing the number of infected patients. So this is the mechanism of infection of COVID. You know very well that ACE2 receptors are really crucial to starting the infection. What they did to treat the patients is to use convalescent plasma therapy. This is not an approach that is so theoretical, because also with Ebola, they used the plasma therapy of convalescent patients. And this is the protocol that they use. And they were also the first one to use. This was the treatment of some patients with convalescent plasma, that were patients before and after treatment. Those data are confidential. I have these slides because they shared this data with the National Health Council, of which I am a member, but it's important to understand that this type of approach may be effective. And they started the protocol that is the tocilizumab protocol with IL-6 inhibitors. So this is not an Italian protocol. This is a protocol that they started in China more than 1 month ago. What's about the data in Italy? I will show you now the data in Italy that are updated, because unfortunately we have actually more data in Italy. And this is the screen of Italian data. So look, we have actually 2,500 patients that died today. As you can see, we have 26,000 people that are positive and more than 100,000 that have been assessed. And if we look at the date of infection, we have actually the same data that in China. So actually we have 30,000 people that are positive, and of them 25,000 people died. And if we go to Regione Lombardia data, I will share to you with data. Look, we have 6,000 patients hospitalized for symptoms. And in intensive care, they are close to 2,500. And in the Regione Lombardia, the people that died are 1,420. So many of them. So it's really a nightmare, actually. And this is the way of epidemics. Look, we had first a decrease and then an increase again. We expect the acme of this during the weekend. Going back to my presentation in PowerPoint. So these were the data of yesterday, to you the data of today. So this is the clinical pathway for patients in Regione Lombardia in order to define who are the patients who should go in intensive care unit or in CPAP. This is the protocol that we use for the management of the patients. So the antiretroviral treatment and the protocol for the dosing of tocilizumab, that is a protocol, is not standard of care. And this is the expected number of cases in the next days. We already reached 30,000, so we predicted. So we believe the outbreaks will be reached during the weekend, so we will have more cases than in China, and we hope then in a decrease for the social isolation. If you look the data to the other countries, look, in Spain, we have exactly the same data, and if you look, USA behind Italy, look, it's here. So it's not different what is happening actually in Italy. So this is really a pandemic. We have to be really careful. So for oncological patients, we decided with the National Society to stop any follow-up visit, any ambulatory visit, to stop any access to the hospital outside the patient, to use PPE for all the doctors, and to give priorities for treatment in terms of surgery and medical treatment. And so we paid a tribute to Spain, France, and USA colleagues for your fight against COVID. I am sure that now USA are interested in the problem. I am sure we will make advances, but until now we need to do social isolation and containment. That is the best prevention strategy. So now I give the word, I stop the sharing and I give the opportunity to Daniele to share his screen. Okay, just 1 minute, stop sharing. So go, Daniele. I mute myself.
Hello? Oh, it's okay? Okay, thanks, Giuseppe. I completely agree what you show us about an overview what's happening in China and Italy. And just want to share with all of you what happened in the first red zone in Italy. So in our areas, from Lodi and Cremona, is just two small towns close to Milan, happened the first patient 0, patient 1. We don't know exactly, but in 3 days it spread all over around. And I'm trying to be rational, explaining what is going on, hopefully without emotional in what I'm talking about. First of all, I want to highlight again, based on the data we have so far, that men are more hospitalized severely compared to the women. So the ratio is 1/4. And especially more confined in from patients all over the 50 years old. And so basically in agreement with the data we have from China. And what's in the D-Day was the 24th of February, and it was a tsunami in that days, because around Friday, around the weekend, we wasn't really prepared, what happened. So we have to organize rapidly things and try to learn from what's happening in China. So first of all, what we've done was the mayor of the town, in agreement with the county, completely induced severe restriction on the area, independently of what the government said. Because in 3 days, we have more than 500 admissions to the hospital. And think about that, our hospital has 1,000 beds. So we weren't able in 3 days to control all the count of admission. And so in a weekend, the first policy was to induce restriction to lock down everything around. From obviously only pharmacy and drugstore were opened, but all the others, also the companies or the industry, was locked down in 3 days. Because in order to reduce the spread of the disease around. Unfortunately, it was only used in the area, but not around the area. So we have to wait from the 24th of February till probably last week, that all the red zone was claiming all over Italy. So I really recommend the restriction that China used, Italy used, because it's really safe for people, for patients, oncological patients, for preserving hospital from the tsunami. Because it's more easy to treat patients and to take care of patients if the wave of hospitalization is gentle, not isn't a hit, because you understand why. And the second, what we're trying to do, speaking about the normal population, then a general population, sorry, but then we focus on oncological population. We try to preserve area from coronavirus-free, from coronavirus positive patients, because obviously we need to take care. We are not an oncological institute. We need to take care of over the situation, from stroke, from heart disease, from surgery, and also from corona positive patients. So we try to keep safely area from one another to another. So it means that before entering the hospital, we try to check the anamnesis of the patients, if they have fever, cough, all the symptoms that Giuseppe Curigliano showed to us. and in order to have a filter before enter the hospital, and address accordingly a sort of triage according to the disease, to send from a triage to emergency room for coronavirus patients, positive patient or supposed to be, versus patient with no symptom related to coronavirus or with other very serious disease like heart attack or stroke. So, and then the second, we try to, in the first hit, to organize all the all departments in order to be able to address all the clinical needs for severe symptoms related to coronavirus, because in the first week we have very high numbers with severe condition. We realize that the first stage in this kind of patient, X-ray is not enough. Only CT scan will help us into define precisely what to do, and to address to intensive care, to or other department with CPAP or mechanical ventilation or oxygen supplementation. But CT scan was more helpful in understanding exactly what to do in this first hit. And now we are more confident, and now we have probably, even we still in the high peak of the heat of the disease, but we're more confident in managing this kind of patient, and also we have a chance to see early phases of disease, and X-ray could help also in order to address us in the first round. And the second point is apart of the oxygen supplementation, all the devices we used, but also the treatment. Treatment was based on hydroxychloroquine, retroviral treatment. Sincerely, I'm not sure they really work perfectly. Just to remind what the release from the company outside today, they not recommend to use them. I gently recommend to use drug able to inhibit the cytokine pathway from TNF, IL-1, IL-6. TNF is the first cytokine that appears during the inflammation. The second one is IL-1, and the third one is IL-6. So, in a way, IL-6 is always really high, or is tocilizumab work in the patient where the disease is quite heavily advanced. But if it's possible to find patients in early stages, I recommend anti-TNF like infliximab, and using rheumatoid arthritis. We started using them, and it works perfectly in order to stop in an early stage in the disease. And also we have already 20 patients under treatment with tocilizumab, and working nicely, but it's better to use not the last stage, but try to use in a medium late stage, because otherwise you are in a loop of cytokines and it will not work perfectly. So, and apart the strategy in terms of hydroxychloroquine, paracetamol for patients that could not be hospitalized, but you can control staying at home, the other treatment will recommend to use as first as you can in this kind of patient in order to block the loop. The other, because the numbers are so high, what we have done in patients with symptoms like cough, fever, but not positive X-ray, we try to stay connected with them at home in order to modulate and to coordinate with GPs all the treatment, and at staying at home, all the treatment and medication, and at home and not in hospital, in order not to evitate the congestion of the hospital as well. About the oncological department, fortunately we have a dedicated area to oncological patients. In a sort of ways, as I might say, it's a sort of corona-free, because parents are not admitted, all the caregivers are not admitted. They are a dedicated area, but are not admitted to enter in the day hospital or department. And we control all the patients with symptoms, and try to we administer all the treatment, and obviously monitoring all the clinical symptoms and hematological background. The others, we have really few patients. Now I could count 4 patients, only 1, so only 2 are really severe, but the condition we start with is metastatic in a very rapid way. So I don't know if it could be a really good address. We don't have 9 numbers of patients that are corona-free, maybe because oncological patients and their caregivers are more careful of taking care of themselves compared to the other part of the population we are facing on. So this is my address. Also, I really would like to thank U.S. government, because tomorrow we have new physicians, new MDs and nurses from U.S. and we are they are building a new hospital close to our hospital to taking care of patient in a mid stage, where we cannot no need to be hospitalized, but we can not be sure and be safely to take care of home. And thanks to the joint venture we are with the US, and I'm really proud of that. Thank you very much.
Dr. Generali, thank you very much for this wonderful presentation. Dr. Curigliano, as always, wonderful presentation. Now I think it's time to come into what we all want to start discussing, and that's the roundtable. So I'm going to go ahead and kick it off with a question that we had from one of our Swedish colleagues, and they ask, which criteria are you using to test doctors and nurses? Are you testing only symptomatic people? Do they need a negative test to come back to work? How do you prevent the staff from being infected and becoming super spreaders? This is a question that is very big on everybody's mind as we all work with the same thing. So what is your take on it?
The beginning in Italy, we started testing on every patient. So on every subject in the red zones. In order to identify patient number 0 and patient number 1, this was the only way, finally. But since 10 days, actually, we are testing just patients admitted to hospital with symptoms. So it means that if I will have fever in the next 2 hours and I don't have respiratory symptoms and I will go home, I will not be tested, so I will not be a positive case. So actually in Italy, we are testing in Italy. This is the major advice of the national health system, but in some region, and Daniele can confirm this, they would like to test any subject in specific communities. So the denominator is completely different with respect to the denominator in China. So what we do for patients, if they have symptoms, so cough, fever, and there is a suspect of a coronavirus infection, we test the patient. And the same thing for doctors and nurses. Daniele, can you comment on this? You are unmuted.
Muted now? Okay, good. Completely agree with that, and we are following the same procedure. And otherwise, if you can test everybody, will be we increase the denominator. So as Giuseppe said, and also if we have positive cases in our colleagues, obviously they will be sent home, but we are not tested for corona, even we are not symptomatic. And in next, what is going probably next week is going to test the immunocompetition, testing the IG, immunoglobulin M and G, in order to see if patient or colleagues or people that stay close to positive cases had developed immunocompetence, even asymptomatic, to coronavirus. It could happen. And we have a rapid test maybe it's not so precise as the blood test as usual, but with a single drop of blood, you can test it, and you can sort of way of judge if you are immunocompetent or not with, against coronavirus. Could be maybe easier instead of performing coronavirus all over the country, all over the people.
Thank you, gentlemen. And with that, the floor is open.
I'll start with the question. So I think one of the big questions we're facing as oncology providers are those people that aren't affected with COVID-19, how we're tailoring their therapy. So you did mention in your presentation, Giuseppe, that you're pushing out surveillance patients, those patients that, you know, maybe on an oral aromatase inhibitor are coming in for scans, that's probably not worth the visit to clinic. How are you handling patients on adjuvant curative chemotherapy, where, you know, decreasing their immune system might make them more susceptible? And on a similar thread, how are you handling metastatic patients to which, you know, each individual week of treatment may not be necessary, but they do need to get therapy over a several month period?
So there is no evidence-based approach, of course. For patients on adjuvant endocrine therapy, we don't have any specific recommendation. So we suspended any type of follow-up. Of course, the patients are contacting us, but we say them, you should be managed exactly like any other subject. So social containment, use protection if you go to do shopping or something like this, don't go away, don't go around. So exactly the same prescription as normal subject. Regarding patients with indication to neoadjuvant and adjuvant treatment, if they already started treatment and they have no sign of COVID-19 infection, we try to maintain the treatment and we intensify monitoring. If you have a new patient that should start a neoadjuvant treatment, if triple negative or HER2 positive, of course, if at the screening they don't have sign of coronavirus infection, we try to start treatment without any delay. Of course, if you have a patient with ER-positive disease, with the T3N1, that usually you propose an neoadjuvant chemotherapy. In this case, we propose surgery. So we don't deliver a chemotherapy where you don't have the opportunity to impact on survival and on outcome. Regarding surgery, any type of surgery that can be delayed for DCIS, for ER-positive disease, small tumors, we try to delay. We don't delay surgery, of course, for patients in the post-neoadjuvant setting. We don't delay surgery of lung cancer when you can achieve a curative intent, very limited stage. And we are very careful for non-small cell lung cancer patients. Actually, those patients are very intensively monitored because we know all the infection for coronavirus that we detected in our hospital are patients with head and neck tumors and non-small cell lung cancer. So we have to be very careful. And all the doctors positive in our hospital are doctors from the team of the lung cancer program and head and neck program. So we need really to have very strictly procedures for those doctors and patients. I hope I answered. There is no evidence-based procedure here, but this is what we did. I don't know, Daniele, in his hospital, what they did.
Basically, as you said, we don't have evidence-based, so we try to follow what was the best thing to do for the patient. So basically, we continue treatment ongoing, or we decide, independent of change in terms of surgery or chemotherapy, if this kind of approach will impact on survival definitely. So we postpone any possible surgery, like Giuseppe said about DCIS or whatever, or maybe if a patient is under safely treatment on neoadjuvants, like an elderly patient with aromatase inhibitor, we try to keep them at home and monitoring, or also a patient with under TKI, for example, in a lung cancer or other solid tumors, whatever. We try to monitor them precisely, keeping them at home with a restriction, as we mentioned before, but also constantly be online with them, and in order to play safely both sides, and be open to any urgency a patient requires, obviously. So first of all, I say just support all the decisions will definitely impact on survival of our patients. Keep going what we basically need, and try to take all the procedure or restriction we need or we know so far in order to preserve a situation in hospital or our patient. Everything that can be monitored, staying at home, using devices, medical devices, will be recommended.
Excellent. Thank you very much. I have one question. When it comes down to oncological treatment, of course, if a patient tests positive but have mild symptoms, what do you do then? What is the reason when a patient comes to the ward to receive a treatment, but they have a mild cold and you don't know if it's coronavirus or not? And if it's a curative treatment, do we do anything? And the final question, how do you reason if the patient has had contact with a corona-infected person but doesn't have any symptoms and is scheduled for a treatment?
Giuseppe? Or
okay, regarding, yes.
So what we've done is a patient under treatment, but developing symptoms related to coronavirus, and we tested positive for corona, we interrupt the treatment.
We do the same thing. We do the same thing.
The patients, a patient living or with caregivers, one is positive, and the patient will be, if he's a patient living with a positive for caregivers, we test the patients just to be sure. But in other way around, if a patient is positive without symptoms, we suspend the treatment, or we don't test their caregivers. And if a patient have symptoms and we don't know we don't have any clue, we try to test for coronavirus as soon as we can in order to understand what to do.
Thank you. Next question.
I have a question. Thank you both for excellent presentations, and many of my questions has been answered by you. So it's very interesting to hear you discuss about priorities. But I also wonder, if we have a patient that's had treatment, for instance, chemotherapy, and get the virus, what can we expect? What's the progress like?
I have a patient. I have a personal experience of one or two patients.
Mm.
First patient was a patient from Bergamo, that is another new red zone, and he was receiving finally a tyrosine kinase inhibitor in the context of a clinical trial. It's an anti-RET, it's Blue 667. So he was a lung cancer patient with a RET amplified. And he received 3 courses of treatment with an excellent response. And after the 3rd course, he developed rapidly cough and fever. And what we did, we suspected a COVID, and we applied the procedure in Regione Lombardia. So we contacted the 911 of Italy, and the patient was hospitalized, and after 2 days he developed ARDS. So of course, in a patient like this, he's still alive, but he's in critical condition because actually he has multiple organ failure. So I mean, if you have a positivity during treatment, you have to stop treatment. Because if the patient has mild symptoms, maybe with appropriate treatment, you cannot have a fatality case. So it's quite important to understand that you cannot deliver any tyrosine kinase treatment, any immunotherapy, or any actually treatment with chemotherapy if a patient is positive. I have another experience with a patient receiving immunocheckpoint inhibitors, specifically phase 1 study with an anti-PD-L1. It was very interesting because the patient was receiving treatment since 1 year. This was an endometrial cancer from Vimercate. This is a small city close to Milano. And 2 weeks ago, she developed fever and cough, exactly the same. She came to the hospital, so we tested her in the hospital. She was positive. We did not give any treatment, of course. We decided to stop temporarily immunotherapy, but she recovered. Actually, she has no fever, she has no cough. She did not develop a serious pneumonitis. I don't know if she was receiving immunotherapy or not. We don't have this data actually with Marlen Koch in the Netherlands. I am sharing all the data of patients on immunotherapy just to understand if they have a different outcome or not. We don't have any information on this. I have experience of a patient receiving chemotherapy and radiation therapy for head and neck cancer. And again, this patient was positive and we stopped any type of treatment. Actually, he is not in intensive care.
So I have a couple of questions, actually 2 questions. First of all, I congratulate you for kind of hanging in there and really sharing your information with us. I think it's very important that we learn from Italy and that you really also share your treatment approaches for individual stages of this disease. The question that I have is, clinical research. How are you handling clinical research patients that are on trials right now that have to come back to certain appointments and will probably not come back to appointments? Are you consenting patients right now for new research? Has everything come to a halt in Italy right now? I mean, what is going on with regard to clinical research?
This is really a mess. In the last 2 weeks, we did, as a center, more than 500 protocol violations. Because, you have the delay of treatment because patients are coming from area outside Lombardia and it's not safe for them to come here. So what I did protocol violation to send the medication home that are experimental medication. So we organize with our pharmacist the delivery system. And all the companies, I would like to thank Novartis, Roche, Blueprint, Tesaro, GlaxoSmithKline, that agreed to stop admission to the hospital for the patient, agreed to do all this violation, and we are submitting a lot of protocol amendments to the ethical committee in order to guarantee this. So for all patients or treatment, I try to do my best to reduce access to the hospital for patients receiving oral medication, to limit the access to patients without symptoms that are receiving immunotherapy, but all the tyrosine kinase inhibitor, any type for any disease, we deliver home and we declare protocol violation. So this is what I did. And I am going to submit this data as a letter to a journal because, of course, it's quite strange the increase of protocol violation in the last 2 weeks.
Right.
Just to completely agree with Giuseppe. Just today, I was sent on a mail to the hospital and all the companies just to apologize about in these 3 weeks of tsunami because we have really a large amount of violation. What we have done is we stop any recruitment by now, even in phase 1 trials. We submitted and we sent when possible by the pharmacological companies at home orally available drugs, and only in one case we send the experimental drug for injection to an hospital close to the patients in a county, in a region called Marche. And from next week, we would like to start with some protocol where we can manage safely according to the restriction we mentioned, but basically is 4 out of 60. So that's what we're doing. So really agree with Giuseppe.
Daniele,
also,
we are doing
apart from the drug, the real problem we are facing is all the imaging approaches, because
we
are completely focused to the corona patients. So CT scan, PET scan, whatever. So just completely blocked.
We do at home, and we ask the patients to send us the images, and we will check here. What is very important, we reduced the accrual. But in case you have a patient with metastatic disease for which you have a drug in which there is a clear clinical benefit, despite in a phase 2, let's assume you have a RET amplified patient or an NTRK amplified patient, and you have the drug, we try to start treatment. So for those selected patients, we try to deliver therapy. Another example is endometrial cancer or colorectal cancer with microsatellite instability, or a patient in third line with an HER2 positive breast cancer for which there is a potential access to trastuzumab deruxtecan. So those are selected cases for whom we try to deliver treatment.
Yeah, completely agree with that. Thanks, Giuseppe.
So another question, I know multiple therapeutics have been talked about today, chloroquine, infliximab, tocilizumab. Giuseppe, you were mentioning convalescent plasma. Do you have a program set up in Italy that you're currently collecting that, and what results have you seen?
We discussed about this with the head of the National Health Council, that is Franco Locatelli, that is an expert in transplantation. We are very skeptical of using the plasma of patients from China, because you should know that a delegation of 10 Chinese medical doctors arrived in Italy and visited many hospitals, maybe also the Daniele Generali's hospital. But we are very skeptical in using plasma from patients coming from another country, because we don't know the procedures for collecting them. There is actually no protocol active in Italy on plasma of convalescent patients. I believe that looking at the Ebola patients' experience, I read all the data. It's not something that cannot work. Potentially it can work. So my advice is for the hospital that have large volume of those patients to test this, because it can be useful for some patients.
As far as I know, there's one hospital in Pavia, San Matteo, is going to submit to the AIFA, or the protocol using the plasma, establishing a network in Regione Lombardia of hospitals interested in this procedure, with obviously, as Giuseppe said, with a strict procedure in order to homogenize the system, and then safely export to the other centers.
Thank you.
So, Mr. Chairman.
Yes, I'm sorry about that. There's problems with the microphone. So this is a question coming out of the ESMO Young Oncologist group on Facebook. And this is, how do you deal with patients that are undergoing immunotherapy and have impact of immune-related adverse events and are under immunosuppression and are starting to present symptoms of coronavirus? Do you de-escalate the corticotherapy, or do you keep it?
We don't have experience to answer to this question. Personally, I don't have any patient with immune-related adverse event with the concurrent coronavirus infection. I suppose it will be a mess. So I hope the patient will survive in case we'll have a pneumonitis related to EP Nivo, let's say, and the coronavirus infection. So, but I don't have any personal experience.
Either, we don't have it. Sorry.
One other question coming from the OncoAlert site, that's if a cancer patient has recovered, when do you think it's possible to restart treatment? I know that it's kind of early to have these kind of questions.
Considering that some patients can be also positive despite a test that is negative. In my experience, since I had 3 patients, only one started treatment, but 6 weeks after the positivity, with no symptoms and with serial testing that were negative. So 6 weeks after the event.
Yeah, so it's the same procedures are with that. What we are going to add, as I mentioned before, we will test the value of immunoglobulin, EGM,
Yes.
AEG, just to see if we have immunocompetence, and in order to, if we have high IgG, would be placed safely for the next future.
Okay, I have a couple of questions that might also be very specific, but it's from our clinicians. They ask, should they be more generous with G-CSF during cancer treatment than normal? And also somebody read that it could be even worse with steroids. So should they be avoiding steroids as a part of the antiemetic procedures?
No. You should apply exactly what you do in standard of care.
Okay.
You don't have to give steroids, or you don't have to give more growth factors. So
okay.
Patients should be treated as the best of care, Then if you have the complication, you have to manage it. You should take into account. So it's very important to screen before starting treatment and to do close monitoring, but you don't have to change nothing.
Perfectly.
Okay, can I ask you a question in terms of, you must be running out of healthcare professionals, over time that are negative, unless you allow providers who are tested positive to go back to work and care for patients with COVID-19. So, how are you handling this? Because, with this high prevalence of this virus in your population, it must affect the healthcare professionals, quite a bit, So how are you dealing with shortage of nurses, physicians, etc.?
We have to work actually, even if we are positive to the test. We have to protect ourselves and to protect the patients. So we have PPE, but if we don't develop symptoms, we are allowed to work. This is actually the procedure just for medical doctors and healthcare professionals. For other people, they should be in quarantine.
Yeah.
Okay.
One quick question. Over the past couple of days, many of us have been seeing information about potentially using acetaminophen to lower fevers instead of ibuprofen or NSAIDs out of a theoretical risk because of the ACE receptors. Is that something, did that just come out of the internet? I couldn't find a real good biologic reason. Are you guys avoiding ibuprofen?
No, you should know. This is really a very, very interesting. My wife is working in intensive care unit, in the COVID unit, and some people working there, some doctors, were taking ACE inhibitors because they believe it's a preventive treatment. So, of course, I know that there is this association that it is not scientifically proven that many patients assuming ACE, but this is, I believe, not scientifically demonstrated. Believe me. An expert in Italy that is Giuseppe Remuzzi, that worked a lot on these drugs, is convinced that are protective rather than detrimental, but nothing scientifically has been demonstrated.
Yeah,
despite many patients in intensive care unit are also have also hypertension, and we're assuming ACE inhibitors. Yes.
Absolutely. People need to take care of this news.
Yes.
Okay, well, now I have to do my role as moderator and inform everyone that it's 8 o'clock. I don't know, we would love to continue this. I don't know, I know that Dr. Curigliano is very busy right now, so I don't know if he has the possibility to stay an extra 15, 20 minutes or if he must go.
No, I have to go because I have to speak with the doctors what they have to do during the night.
I
Maybe
understand.
Daniele can stay. I don't know if Daniele can stay. Yes.
Yeah, I need to few because I had to come back to the hospital now.
Yes.
Oh,
So
I
same for me.
understand.
Okay.
Then I guess we must begin to wrap up. I thank everybody for being here. And what I would love to do is I would love to take the next 10 minutes or 5 to 10 minutes. If we could just wrap up as far as what we would like to give, the knowledge that we'd like to give the rest of the world in getting better prepared to deal with this pandemic.
Yep. Sorry. Hello.
Yes.
Okay. Yeah. In order to summarize, wrap up everything, the first one, following the restriction that all the governors suggest to population, to all of us, in order, because if you follow them, we really protect ourselves and also patients and all the people. And in order, first, the second one is when I call the numbers, the free call numbers, or all the hospital when you have real symptoms, and don't be panic, because the doctor are there and could not take care of you, but because there's a lot of question, we need to address properly what to do, and in all the situation. Above oncological patients is that all the doctor, the oncologist will take care of your disease according to the standard guideline we are following, and in order to decide what is definitely definitely used for saving your life as a patient, and what will be postponed by oncologists is just because it's not an urgent approach and we can then postpone. So following that, what the physician will say to you.
And another recommendation on my side is to concentrate resource. Don't forget that you will need intensive care bed unit that should increase. So concentrate patients, resource, and healthcare professionals. It's very important to plan everything because the patient will arrive. So it's important to be ready. This is not a flu, believe to me. I saw a lot of patients dying every day. Today died more than 350 patients in the Milan area. So consider all of this. And I really hope that will be done a global effort. So we really need the help of any country, and primarily from the United States. I hope they will do a lot of investment to find a vaccine, because I believe that only a vaccine strategy can really impact on the spreading of the virus. Until then, we have to do social isolation and containment strategies.
Oh, great.
Excellent. Thank you very much. If you were to give the biggest piece of advice you could give to the countries that are bracing themselves for the effects of this pandemic, what would it be?
It's exactly the same what we said.
The same.
So
Okay.
in Spain and France, they have to start as soon as possible social containment and isolation. There is no way to flat the curve. There is no way. So do not under-evaluate if you have 10 to 15 cases, because it was exactly the same in Italy during that dramatic weekend. And in 3-4 days, and now after 3 weeks, we had more than 30,000 cases. So this is the recommendation. Start social isolation and start social containment as soon as possible.
And try to, as quick as you can, learn from our experience in order to organize properly the hospital, the intensive care units.
Excellent. Gentlemen, thank you very much. We really appreciate your presence. We understand that you are there in the front lines taking care of patients. So we really appreciate the fact that you took this time to share with the rest of the world the experiences that you're having right now. The rest of us, thank you so much to our friends from the US and from Sweden. However, we can continue. We must say goodbye to our Italian friends, and the rest of us can continue 15 minutes more. we thank you very much, Professor Generali, Professor Curigliano.
Thanks a lot. Bye-bye to everyone. Ciao.
Bye-bye.
Ciao.
Ciao. Take care.
Take care.
So there you have it, everyone. Those are the advice that we had from our Italian colleagues that are dealing basically in the front lines of this pandemic. We've had some great questions. Any reflections from the rest?
Yeah, scary situation. No way to flat the curve. I think it's very powerful messages.
Yeah. I completely agree. I think it was very helpful for us to hear firsthand information about this tsunami they talked about. You know, they were completely unprepared for, and we have no excuse now to say, you know, we are not prepared. We didn't know what was coming. We have the benefit of being behind Italy and China in a way that they were. We should be better prepared. No one can say, you know, we didn't know, and no one should say this is just the flu. We need to save lives by flattening the curve.
No, I think many people are wondering what they can do. And I really think for this, the biggest thing an individual can do is to socially distance themselves and influence whatever friends or family members that they have to do that, because I still think a lot of people aren't, and that's going to make the biggest difference here.
Right. Lena, what are you seeing in a place like Sweden that has a very similar health system compared to the rest of Europe? How is Sweden preparing itself?
I think we are preparing and changing the messages from day to day or hour to hour. And we are, I mean, we have 8 or 9 deaths so far. So we're just waiting the following few days what to do. So I think this information from a cancer perspective was very, very, very useful. And what I'm trying to do is to make our leadership and organizations be aware of the specific sensitivity around cancer patients here, because I think that message is not so easy to get across, because so many people are worried and so many different groups are worried about this. So, but some really concrete tips that came from here that I think that I can use, and hopefully that will be of benefit from our hospitals. I'm also thinking about all our staff, how we should manage, and how many long shifts, and how we should recruit. I mean, coming from a situation where we already have a shortage of physicians and nurses, quite severe in cancer care, that's also on top of everything else. So worrying for sure.
Excellent. Felipe, what about your take in Brazil?
Yes, in Brazil here, we are, I think it's interesting data that Giuseppe showed, like how many days behind each country is from which country in the epidemics. Here in Brazil, we are 17 to 18 days later if you relate to Italy. Most probably the epidemics here started with imported cases from Italy, because we have a very huge Italian community here in Brazil. I think people become scared in the last couple of days. I see TV shows, everyone is talking about it. Social isolation is working. It looks like it's a holiday. Every day you go around, see less people. In the hospitals, we are trying to organize to spare beds for people that will come with the COVID-19. In my specific hospital, we had 8 cases Friday. Today we have 28 cases 5 days later. So I think the pandemic is peaking now, and I think we learned a lot from the experience. I hope we had learned a lot from the experience from our Chinese colleagues and Italian colleagues as well.
Excellent. I am sorry. One of the realities of teleconferencing is that we all have children, and of course you're hearing mine in the background. He's got a pair of lungs, that one. So my apologies. But we should get ready to start wrapping up. So I would like to end this. If we could give each one of us one specific thought to the people out there as far as the message that we're trying to convey worldwide?
I'll go first. I'll say that I think social distancing is the most important, but another takeaway from this, I think, is that we're all very data-driven. We're used to trying to offer patients what's data-driven, and we don't have a lot of data on this about what should be postponed, about what should be reduced, which patients currently need therapy. So I think that's really an individualized decision and something that we're all going to have to realize that we're operating a little bit in a data-free zone.
And I believe, everyone will recognize we're at an inflection point in terms of, recognizing 2020 as something that will stick in the memory, in medical memory, and actually society memory, something that changed the way we interact. And hopefully we'll learn the lesson that we'll actually have more redundancies and more capacity in our healthcare system. And because especially in our commercial healthcare system in the United States, we're always operating at capacity. We have no way to deal with emergencies like this is what we're seeing right now, because every ventilator is being used, every ICU bed is filled, with routine patients. And that is something we need to be aware of, because it's not going to be the last pandemic we're facing. We need to learn our lessons from what's happening right now, what works and what doesn't work, and really be more vigilant in terms of, worldwide connectivity that we have right now. So I very much appreciate this international effort that OncoAlert brings together to really inform each other what is happening and how we can be prepared for this, what's going to come to our countries.
I just want to echo that, Axel and Erika as well. And I think even as simple things as PPE, there's no real excuse not to have a situation now when we're running out of equipment, basic equipment to protect our staff and our patients. So I think that's something to learn, and a lot we should learn. And also what was mentioned many times here tonight was try not to panic, because panic mode is not going to help us at all. We need to stay calm, and we need to look after ourselves and also our patients and families. So I think we need to bring up all the goodness in ourselves to be able to tackle this together.
Yeah, Felipe?
I think I agree with all what that was said today. I think we are learning as a society what is happening here now. I find maybe it will be interesting in a couple of months or years to see how we as a species, right, more than countries, how human beings, how we deal with this epidemic, how we learn, how we're going to prepare to the next. I think maybe this is the first epidemic that we see in a real global world where we have communication information going all over. So I hope we learn a lot from this episode, that we go well in the future, and that we're more prepared for the next ones.
Exactly. And as far as me, we're all gathered here through the beauty of social media. We are all parts of or members of the OncoAlert network, which was actually formed a year ago exactly for this kind of situations. We were not aware this was going to happen, but now that something like this has happened, it has brought us together more than just our common fight for oncology. Now we're fighting against this pandemic, and it's the wonderful beauty of using these tools. The one thing that I would like to tell people is to make sure that you get your voices heard, especially if you are doctors. There is a lot of misinformation out there, and it is our job to go out there and fight it. Now, this doesn't mean we can go out in the street. You don't have to. This is happening on your Facebook. This is happening on your Twitter. And believe me, people will appreciate the fact that you actually stood up and said, this is wrong. This does not have any scientific background. Please stay away, stay home, take care of yourself. And if you have any of the symptoms, get checked. Call your doctor. Don't go to the ER. Very, very simple points, but it takes having physicians or having people from healthcare, nurses, doctors, scientists, putting these thoughts out there. So urging all of our friends, all of our colleagues to go ahead and take this battle. So I thank every single one of you. Thank you very much. It's been a wonderful round table. And with that, I guess we can close up. Felipe?